Thank you very much. Okay, up. I put my words. Excuse me for my bad English. I have my notes. I think it's most security for you. Good afternoon, and I'd like to thank the scientific committee for the kind invitation on the chairs, especially to Ornella Corazza. Thank you very much. To speak at the inaugural conference on the clinical use of psychedelic substances in Italy. My talk today address more specifically their use and their potential efficacy among patients with addictive disorder. My conflict. Addictive disorders represent a serious public health problem, not only in France but throughout the world. The sum of the right and indirect cost of patients with psychiatric disorders totals over 160 billion euros per year. Patients with the disorder, both psychiatric and mental disorder, require specialist care for an estimated 10.2 billion euros per year. While this represents a significant figure, it is a small fraction compared to other indirect costs. As you can see in this chart, the majority of these costs are related to premature death and decreased quality of life. There are also patients who present significant difficulties in securing meaningful long-term employments. The loss of productivity is over 43 billion euros per year. This is just 1 year in the patient populations that suffer from a chronic lapsing conditions which can last for years. It's not a decade. Among the psychiatric and mental disorders, substance use disorder represent a leading cause of morbidity and premature mortality. In fact, tobacco and alcohol use are the two leading causes of avoidable death in France. Approximately 50,000 deaths per year are attributed to excessive alcohol use. The main causes of mortality are cancer or cardiovascular disease. Hospital admissions, primarily for the emergency department, are also steadily increasing. These are largely the result of acute intoxications and complications from excessive use, including severe withdrawal symptoms. These from use total around 75,000 per year, the result of cancer, cardiovascular, and respiratory failure. A major obstacle for preventing these consequences is the lack of effective treatment for patients. Meta-analysis show that after alcohol withdrawal, about 50% of patients will relapse to alcohol use disorder within the following month. When we further examine data show in table on the right, we can easily see that the majority of the currently available treatments have either low of insufficient efficacy is treating the symptoms of alcohol use disorders. The graph on the left side of the slides illustrates the efficacy of currently available treatment for smoking cessation. The most effective treatment is varenicline, is not available now, with 20% of patients who remain abstinent from smoking at 6 months. Other treatment are associated with about 15% quit rates. In the face of such serious and deadly disorders and such poor remission rates, we must explore other treatment options that could provide better efficacy, including psychedelic molecules. I'd like to first present some of potential mechanisms of actions of psychedelics, as well as their potential to counter some of the neurobiological biological modifications seen in alcohol use disorders. Psychedelics can modify cerebral system implicated in addiction at three main levels. We know this. First, the decision-making system, which includes the prefrontal and orbitofrontal cortex, as seen as the top of the figure, addictive processes promote glutamatergic projections between the prefrontal cortex and the accumbens nucleus. Psychedelics can improve cerebral plasticity by promoting synaptogenesis and by modulating glutamatergic transmissions by desensitizing serotonin receptors and reducing glutamate receptor expression and thus facilitating better decision. Next, the reward system comprised of the striatum and the accumbens nucleus in the middle of the figure. Yes. Addictive substances contribute to increased dopamine activation and serotonin sensitivity within the accumbens nucleus, leading to increasing reinforcement and automatic responses. On the contrary, psychedelics act to require cerebral connections, promoting better environmental sensitivity and intensive salience through increased dorsal striatum activation. And finally, the cerebral system, including the hypothalamus, pituitary, and adrenal glands at the bottom of the figure. Chronic exposure to additive substances leads to increased level of CRF and dynorphin, leading to increased reactivity to environmental stress. Psychedelics can potentially restore these imbalances by decreasing CRF and dynorphin levels, as well as promoting psychological flexibility in the face of anxiogenic stimuli. In theory, psychedelic substances will lead to better abstinence, right, due to their capacity to promote improved psychological flexibility, to modulate receptors, and to modify brain connectivity. Sorry. These slides present a meta-analysis of psychedelic trials that were performed in the 1960s, as well as a recent trial by Bogan-Schulz and all. Some studies did not use a placebo comparison or have a randomized design. Nevertheless, they to show that in the month following psychedelics use, there were significantly greater numbers of patients who achieved abstinence in the randomized controlled trials. This result remained significant when the trials without placebo or without a randomized design were included. At 6 months follow-up, there was still a significant difference in terms of abstinence in the randomized controlled trials. However, significant was lost when the other studies were included in this analysis. Let's take a closer look at the randomized control trial by Bogan-Schulz and all, which is one of the largest trial of a psychedelic to date. His study was published in the Journal of American Medical Association in 2022. It included 95 patients with an alcohol use disorder, 49 in the psilocybin group, and 46 in the diphenhydramine group. Diphenhydramine is an antihistaminic which has a slight sedative effect to serve a placebo molecule. Each patient underwent 2 sessions with the designated molecule. Their drinking patterns were evaluated at 36 weeks following inclusion. In terms of percentage of heavy drinking days, we can see that from week 5 to 36, patients decreased the number of heavy drinking days with greater reduction in the psilocybin group versus the diphenhydramine group. From a practical standpoint, psilocybin was associated with fewer drinking days per week versus about two fewer in the placebo group. There was a greater decrease in the number of drinking days in the psilocybin group versus placebo. In patients began with about 1 day per week where they didn't drink. That fell for about 3 or 4 days per week in the psilocybin group versus about 2 days per week in the diphenhydramine group. And finally, there were significant decreases in the number of drink per days in both groups. They both began with an average of 5 drinks per day, with the placebo group failing 2 drinks per day and the psilocybin to 1 drink per day. When cumulated over the 6-month period, these gains could translate to some very meaningful changes for patients with significant improvement in their drinking habits. This study shows to use another molecule that is not a classical psychedelic, but one that has some pharmacological similarities in DMA, is an amphetamine derivative which has been tested in treatment-resistant depression as well as PTSD. Due to its pharmacological properties and safety, it could represent an interesting candidate for treatment of alcohol use disorder. The small-scale preliminary study included 14 patients who received 125 milligrams of MDMA plus 62 milligrams of as needed on 2 separate occasions. The upper left graph shows the IOD severity of each participant. 70% had moderate to severe IOD, alcohol use disorder. All patients had gone through withdrawal and were not currently using alcohol at the time of the study. At 9 months following the study, participants dropped from an average of 18 units of alcohol per day to about 2.5 units per day. There was a clear difference from the start of the study, as shown in the graph, on the lower left for the slide. The other graph of the right shows a comparison with another study in the same institution, but without MDMA treatment. Patients using more than 14 units per drinking day steadily increased from about 1 month following initial withdrawal to 75% versus 71% in MDMA group. Nota bene, there are parallel studies conducted in the same institution. There was no randomized patient selection for each study. This is a second study conducted by another team of MDMA treatment in a patient with post-traumatic stress disorder. There was a post-hoc analysis to see if MDMA had any impact on alcohol use in patients' population. The protocol consisted of an initial administration of MDMA at 80 milligrams with a possible addition for 40 milligrams. Then a second session with 120 milligrams plus an additional 60 milligrams if needed. As shown, there was a significant decrease in audit scores in the MDMA group. However, it's important to note that the initial audit scores were very low in both groups. Furthermore, none of the patients had current alcohol use disorder in this study, and only 1 in 4 had a history of alcohol use disorder. the audit score, maximum score of 40 points. Let's look at another study this time. It's a naturalistic study that we conduct in our service, examining the use of various psychoactive substances and their impact on other substances used, including alcohol, tobacco, and cannabis. Each of the surveys followed a similar design. The subject was asked to recall their most significant of memorable psychedelic experience. They were then asked to quantity their substance used before, the experience, and then in the month and the 6 months following it. So, of course, this study potentially suffers from record bias. However, it could offer some insight for further research. We surveyed 160 patients concerning their alcohol use following a psychedelic experience. Our survey noted a significant decrease in the number of drinking days in the month and the 6 months following the psychedelic experience versus the days prior. It's worth noting that for the most part, subjects were not daily drinkers, and average they drank about one less day after taking psychedelics. As you can see on the left of the slide, about half of the subject had 3 or less drinks per occasions prior to psychedelic use. These numbers increased significantly after psychedelic use. And the heavier using group, the number decreased significantly, especially in those who used greater than 10 drinks per occasion. So, our study shows that generally our subjects drank either less frequently or less heavily after the psychedelic experience. This table compares some of the characteristics of the group that reduced or quite alcohol drinking versus those had no changes. The group who reduced their drinking experienced greater baseline craving and higher audit scores, and included significantly greater numbers of subjects with severe alcohol use disorder versus the group with no change. In addition, the group that experienced the changes in their use had more intense mystical experiences and more frequent fuel psychedelic experiences than those who had no change. The change group also had less psychological flexibility as baseline than the no change group. Let's take a look at tobacco use disorders. This is the only published prospective trial to date. It's a pilot study. Yes. It's a pilot study including 15 participants who had CBT centered on smoking reduction plus 2 psilocybin sessions with the possibility of a third and up to 30 months of follow-up. Compared to baseline, the authors observed a significant reduction of the number of cigarette smoking per day. They decreased were maintained throughout the duration of study. There are also impressive number of participants who remained abstinent at 6 months, 4 out of 5 subjects, and to 30 months at around half of them. When we compared abstinence rates in the psilocybin trial with other currently used treatment, we can see that psilocybin treatment appears to be associated with very abstinence rates and rates at 6 months. However, comparison between the various studies is very difficult, given the very small and reflect select group of patients for the psilocybin study. Let's have a look at the impact of psilocybin experiences on tobacco. Use our naturalistic survey in this part of the study. We analyzed the tobacco use data from 173 participants. I'm going to one word about the flexibility. This graph shows the average number of cigarettes smoked per day before, at 1 month and 6 months following psychedelic use. The survey shows significant decrease in the number of cigarettes smoked, although there was significant variability between, especially at 6 months. Yeah. 2 minutes. Yeah. Okay. One.
It's long.
Just one word about. Sorry. Just this. It's important for us.
Yes.
Just one slide. When we pooled the various survey results to discover the factor that could influence psychological flexibility, our analysis showed a positive correlation between psychological flexibility and mystical experience intensity. This result is confirmed by the fact that those participants who had complete mystical experiences showed a more significant evolution of their psychological flexibility than those who had a less intensive experiences. Okay? I'm going to up to conclusion. Not words for tolerance. In conclusion, primary studies of the use of psychedelic combined with the psychotherapy in treating addictive disorders are quite promising. While we have a basic understanding of their mechanism of action, more research is necessary to fully comprehend their neuropharmacological target and the resulting changes in cerebral connectivity. Initial research has shown that psychological flexibility and its modification may mediate the relationship between psychedelics and their efficacy. Importantly, these molecules are overall very well tolerated and few adverse effects have been described in the literature, including in our survey. Thank you. I'm sorry for the late.
Merci. Thank you. Thank you so much, Amine. I want